general gist of like what is it, action potentials and stuff like that. But especially if we want to go over that again, I won't.
Okay, I'll start with like EKGs and stuff. Can everyone see this fine?
Yeah.
So basically, the key thing to understand is like a depolarized cell. I think everyone understands like depolarization means that you've got the change in ions, right? And so it's normally inside negative, and then when it depolarizes, but the reason why EKGs get a little fuzzy is because EKGs are not measuring the inside like we're used to thinking about it, and they're measuring the outside. So that's what you have to think about when you're thinking in terms of like cardiac and EKG. So if a depolarized cell has a positive inside, it means it has a negative outside. So when the EKG is reading a negative tissue area, that's referring to depolarized cells. So sometimes that can be a little fuzzy. The action potentials in cardiac cells look a little bit different than skeletal muscle cells. And that's because they have the plateau. And that plateau allows the time, I guess, for the muscles to fill. Hey, oh, Lauren, could you possibly put yourself on mute?
Yeah, I was gonna say I keep hearing like interruptions and I can't hear you. And I don't know who has their mic on. Is it possible for you to
Here.
mute people as a result of being the host? Can you like
Yeah, I think she got it though. Sweet. Um, so yeah. So that plateau is basically just a lag time, and that allows times for the atria and the ventricles to fill before they contract. Um, so that's why it's important that that's present. The two different types of action potentials in cardiac cells refers to the two different types of cells that you're talking about. So you've got your myoconducting fibers or myoconducting cells or whatever. And those are the modified ones that can have electrical impulses. So that's like your SA node, your AV bundle, and all of those things, AV node, and all that. Purkinje fibers is the old name for it. And then you've got just your regular ventricle and atrial contractile cells, and those are the bulk of the organ. So the action potentials look fairly similar, and they pretty function similar as well. The main difference to note about them is what causes them to reach threshold. Um, so in the contractile cells, that is caused by, and it's kind of vague, but it's just called stimulus. And that's because it can come from, the stimulus can be caused by one of the myoconducting cells, like the SA node depolarizing and sending, oh my God, sorry, my cat just like fell off the table. Um, anyways, so the myoconducting cell can reach threshold, and that is the stimulus to the next door neighbor um, contractile cell, or that next door neighbor contractile cell, it depolarizes and it sends its stimulus to its next door neighbor. So stimulus is a vague term, but it's basically caused by some next door neighbor depolarizes. Um, and so that's what causes the threshold in the contractile cells versus the myoconducting cells is the funny channels. They're HCN channels. So those are just called, they used to be called like drift channels. I don't know. But to me, drift makes sense because if you look right here, the the voltage just kind of like drifts upwards until it reaches threshold. And then you have the all or none action potential response. So as those sodium ions are kind of just slowly coming in, you get slight depolarization, whatever. It finally reaches threshold, and then you have the rest of the action potential. The rest of the action potential is just like the contractile cells. You've got those voltage gated calcium channels that are opening. You've got your voltage gated calcium channels that are opening. And those kind of have opposing flow of ions. And so that's what gives you that plateau effect. Eventually, the calcium will close, the potassium stays open, more potassium goes out of the cell. That causes the repolarization, so on and so forth. The only big difference then is the funny channels they're called funny because they're hyperpolarization gated. So most channels, when we say voltage gated, are depolarization gated. So when something depolarizes, that opens that channel. The funny channels are the opposite. So when it gets that repolarization caused by the potassium ions going out of the cell, that will then open those funny channels back up, and then it starts the drift again. Because it is kind of random, I don't like the word random, but because it's not exactly caused by like some external stimulus, that's why it's called the pacemaker of the heart, because the heart rate is kind of determined by the speed of which these funny channels open. So if those are reaching threshold faster, you are getting an action potential in, say, the SA node more frequently. That SA node depolarization will then cause the rest of the atrial mass to depolarize, the AV node to depolarize, the ventricles to depolarize, so on and so forth. You can adjust the rate of the funny channels, but I'll talk about that later when we talk about innervation. That way it doesn't get too confusing. Does that vaguely make sense? Cool. Awesome. So yeah, so then that's why we talk about EKGs. So the basic thing for EKGs to understand is where you place the leads is going to affect the reading that you get, and then also the charge of the lead versus the charge of the tissue. So remember, it's measuring the outside of the cells. So I'm going to kind of zoom in. I don't know if this is fuzzy for you guys, but this is all just the stuff that I uploaded in the Google Drive. And it's also like images from his slideshows online. So if you look at these leads right here, I know you can't really see it very well, but this left one is a negative lead and the right one is a positive lead. And the negative lead is going to positively charge tissue. So if the outside is positive, that means it is, anyone? Depolarized or polarized?
Depolarized.
So if it's outside positive, that means that the inside is negative and it is polarized. Sorry, I said D, but I didn't mean it. So if it's negative outside, like this center of the tissue, that means it's positive on the inside, and that means it's depolarized. So, but the negative lead goes to positive, the positive lead goes to negative. They're opposite. They don't like to be opposite, so it gives you a negative reading on the EKG. So the like line that you see will go below 0. Compare that to the third setup that we've got over here. The negative is going to negative, positive is going to positive. They're the same. They like that. Gives you a positive reading. Beautiful. But EKGs are measuring the change in electrical potential. So if there is no change, then it's not going to measure anything. So that's what the middle one is. It doesn't matter the negative and the positive at this point, because the tissue that they're both placed in is both the same. So they're both positive. It's got the same charge. And so I'm not going to get a reading. Does that make sense? Cool. So then now you're talking about the placement of electrodes. So it is measuring the difference, but it is dependent upon the orientation and the plane that the leads are in. So if I have a lead that goes from here, from the top of my head to my chin, and my electrical current is running in this plane, I'm going to get a really strong reading because they're parallel. But if I have my leads placed from my head to my chin, but my electrical current is going from the sides of my eyeglasses, it's only picking up just this little bit that's crossing my nose. So I'm not really going to get hardly any reading. And that's what he was talking about, the vectors. And so I tried to draw it the best I could to scale, but I kind of did a poor job at it. So this first example, I've got the negative lead with the negative tissue, the positive lead to the positive tissue. They're the same. So I know I'm going to get a positive reading. And my vector is in the same plane as my leads are. So I'm going to get a really strong positive. Compare that to the next one. I've still got negative, negative. I've still got positive, positive. So I'm still going to get this positive EKG reading, but my vector is like this. And so it's obliquing that plane of the leads. So it's only picking up this small little fragment that's actually crossing. Again, this is poorly drawn to scale, but I tried. And so I'm going to get a much weaker reading. The same kind of thing is here, but now my leads are in oppositely charged tissue. So I'm going to get a negative reading. If it's in line with the leads, I'm going to get a strong one. If it's obliqued and I'm only reading a portion of it, I get a weaker one. So does that make sense before I talk about how it actually looks with a heart? Not hearing any objections. I'm going to go with yes. So then we get to the heart. So most of the time in a healthy individual where everything is normal, the depolarization will always start at the SA node. Those funny channels will reach threshold that will cause the action potential, that will cause depolarization in the SA node, and then that kind of trickles out and depolarizes the atrial mass or the atrial syncytium. It just means it acts as one being, even though it's individual fibers. So my atria are going to depolarize first. Oh, that was a big squeak. So in a typical lead placement, or it's called lead 2, I've got one up here, my negative lead at the top, and then my positive lead at the apex. And the reason why it does that is more so to pick up the ventricular contraction, because the ventricles is kind of what everyone cares about. So when it starts at the SA node, it's going to start to depolarize from the SA node to the rest of the atria. So from the right atrium area all the way across to the left atrium area. So the vector is, if you want to call it that, is not really in plane with the leads. I'm only picking up a small piece of it. So it is going to be a positive one because I'm still going from negative and negative, positive and positive, but it's going to be a really small one. It's not really a strong vector. So that's what we call the P wave, right? Beautiful. And it's just like a little hump. So then that passes the depolarization to the AV node. For reasons unknown, there is an AV node delay. So that's what we call the PR segment, even though it's not really PR, it's technically PQ. I never really liked that, but whatever. But this flat line where it's 0 because nothing's happening, that is the AV node delay. So when we talk about AV nodal like blockages later, like 3rd degree, 2nd degree, and 3rd degree, in the 2nd degree and the 1st degree, this is kind of what you pay attention to a little bit more. And again, we'll talk about that later. So then we get to the ventricles, or the QRS complex. So he kept drawing this like chicken foot situation, but never really explained what it refers to. It's referring to the septum and the walls of the ventricles. He just kind of put chicken foot up there and everyone's like, what is that? But that's what it's referring to. So again, the heart kind of sits on an angle. So I drew it kind of at an angle. So anyways, for reasons unknown, again, once it passes through the AV node, it depolarizes the left septal wall first. It's just how our bodies work. And then that will then pass to the right side of the wall. So my vector here is super small. It's obliquing the plane. Not a lot's going on there. I'm going to get this really small blip that we call the Q, right? But then it's going to go all the way down to the bottom of the septum, all the way to the apex of the heart, right? Well, that's much greater distance to cover. That's completely in the plane almost. So I'm going to get this large reading, right? That's the R. From there, it goes from the apex up the sides of the wall. And then it's just the S complex. You really don't need to know. I don't think you really need to know all of that, but just in case you're wondering, that's what it is. You can always read more about it later. And you can't really read that very well, but basically what I'm saying is like, because it's going up in both directions, the sum of those vectors that is in the plane picked up by the leads is that like highlighted line that I drew. So yeah, anyways. So the same way that the ventricles have a very orderly fashion of depolarizing, they also have a really ordered fashion of repolarizing. So that's why we can see ventricle repolarization on the EKG and it gives us the T wave. The atria kind of repolarize as a mess, and so you don't really get to see a whole lot of it. And because of like the orientation of the leads and the atria kind of perpendicular to it, you're not going to see anything. So that's why we don't see atrial repolarization on an EKG, because it was kind of just a mess. So here's the action potentials along with the EKG reading. So both of these are referring to just the plain old contractile cells, not the funny channel cells, not the myoconducting cells, like those things. This is plainly contractile cells. So when I get my depolarization in my ventricle, or in my atria, sorry, that's what gives me my P wave, atrial depolarization. It does its thing, it relaxes. This is when it's passing through the AV node, It's going to depolarize my ventricles. That's what gives me the QRS complex. And then it has the plateau. And then as it starts to come back down and repolarize, that's what gives me this nice little T wave. The same thing is this picture. It's just showing you specifically like ventricles, but it's pretty much the same thing. So that is the basis of EKGs and action potentials. How do we feel about that? Any questions, comments, concerns, prayer requests? If not, we're gonna keep going.
I have a quick question, Gena. Sorry.
No, please.
So I guess I'm just confused how we know if it's positive or negative, like based on the vector, like which way it's going to go.
Yeah. So if the charge of the lead is the same as the charge of the tissue that it's going to, same as positive, right? But if they're opposite, they're negative. You may not have been logged on whenever I talked about that.
I don't think I was. I'm sorry, I was late.
No, you're so good. You're so good.
On it.
No, totally fine. But basically, so it's hard to see because I don't have it like downloaded and everything because I'm lazy. But this is the negative lead and this is the positive lead. The negative lead is going to positive tissue. So pop quiz, I guess. If the EKG is reading positive tissue, what does that mean the cell is? Polarized or depolarized?
Polarized.
Yes, beautiful.
I was going to say, I have no clue.
No, you're good. So EKGs read the outside of the cell. So in a normal polarized cell, it's inside negative, so the outside's positive. So this all here that's positive is polarized. And then the inside here that's negative, the outside is negative. That must mean the inside is positive. So I know that's referring to depolarized. That's the weird thing about EKGs that trips everyone up, is that you're reading the outside of the cell. So negative's going to positive is going to negative. Those are opposite. So I'm going to get a negative reading on my EKG like that. Stop. Don't scratch my bed. On the second one or in the middle one, it doesn't really matter what the leads are doing because they're both going to the same charged tissue. And EKGs are measuring the change in electrical activity. But if there's no change, I can't read anything. So that's going to give you a 0 reading. And then on this last one, it's negative to negative, positive to positive. That's the same. They like that. It's going to be positive. Does that make sense?
Yeah, that's much clearer. Thank you.
Beautiful. Wonderful. Cool. So then this sheet was just like, oh, is that the same thing I just had? No. Yes. Okay. I don't know what I'm doing, apparently. But basically, that's EKGs. This is what I was looking for. Cool. So this was the big scary thing that he posted, and everyone just kind of looked at it like, what the crap is that? It's not terrible, I promise. So we just learned what the EKG refers to, right? So we know that the P wave is atrial depolarization. We know the QRS complex is ventricle depolarization, and the T wave is ventricle repolarization. So based on that, you know what the actual heart muscles are doing once they're depolarized, right? So if I have my atria and they're depolarized, that means they're going to contract, right? So most of the blood from the atria passes through the AV valve passively. The actual contraction just gets that last bit out. And it does that passively because the pressure in the ventricles is so much lower than the pressure in the atria. Because if the atria is full of blood, ventricle is empty, the pressure is different. Does that make sense? Cool. So that's why it passes through. Key point to remember, valves are opened and closed by pressure differences. I know in anatomy, we're learning about the chordinae tendonae and, papillae muscles. That's great. But for this, just focus on pressure differences. So they depolarize, they contract, they get that last bit of blood out. So the ventricular volume, which is what this line is referring to, is going to increase, right? So at this point, I have the most blood I can possibly fit into my ventricles. So if you look right here, it's about 130 milliliters on this graph. We'll talk about terminology later to go over it, but this refers to the end diastolic volume. It's called diastolic. Diastolic means relaxation, even though you're like, the atria just contracted. That's not relaxation. Diastolic and systolic in this sense are referring to the ventricles. So the ventricles were relaxed during this whole time, just receiving all the blood. And now it's about to contract. So this is end diastolic volume. Cool. So now my ventricles have all this blood, right? And the EKG, we can see that it's about to start depolarizing. The AV valve is going to close because now my ventricles have all that blood and the atria have none. So it's like, you have a higher pressure. I don't want you coming back up. I'm going to close now. So once the ventricles depolarize, that's going to start the ventricular contraction. So at first, all my valves are shut, right? And when it starts to contract, the pressure is going to jack up because all my valves are closed. The volume of the blood is not leaving, again, because all my valves are closed. So that's what it's called, isovolumetric contraction. That's all that terms mean. Same volume, but I'm contracting. That's going to cause this pressure to absolutely spike, right? And that's going to force the aortic valve to open, or the aortic semilunar valve. So now all my blood is going to rush out into the aorta because there's no blood there, low pressure. It's going to follow the path of least resistance. And so my aorta is going to fill with blood, which means that I'm losing blood in my ventricles. That's why that goes down. As my ventricles repolarize and start to relax, they're out of blood now. The aorta is getting rid of its blood to the body. This aortic valve is going to close because there's no more great pressure from the ventricles forcing it open. that closes. But now the atria have been filled with blood during this time period, right? From the vena cava or whatever, or the pulmonary arteries, pulmonary veins, I'm sorry. So now there's a lot of pressure in the atria again. My ventricles are now empty because I just got rid of it all. So that pressure is going to open the AV valve again. And then I start the whole thing over. There is a period of isovolumetric relaxation. I forgot to mention that, but basically it's the same thing as isovolumetric contraction. It's just where it relaxes and no blood is filling it. So it's where all my valves are closed and it's just relaxing, but no blood is coming in or out. Isovolumetric, same volume. So then this is where I said the atria, the great pressure in it is going to open that valve and it's going to fill it passively. So if you notice, I haven't had my atrial depolarization yet. I haven't had my atrial contraction yet, but my blood is flowing into the ventricles. At first, it happens super fast, right? Purely like gravity at that point. That's rapid inflow. Diastasis just means it slows down, which you can kind of see there. When I finally get my atrial contraction and it squeezes that last bit out, I get that last bit and that whole process starts over like we just talked about. The only other thing that's on this that has any meaning to us are the sounds. We really only care about S1 and S2, and it refers to turbulent blood flow. So S1 is the systolic sound or the lub sound. And that is the sound that occurs when the aortic valve opens or AV valve closes. It's kind of weird, but basically it's just the turbulent blood flow at the beginning of ventricular diastole. The second sound, S2, is the turbulent blood flow sound when the aortic valve closes. Yes, it's when valves close and you get the turbulent blood flow. Sorry. So AV valve closes and there's like the whooshing of blood against that valve. That's S1. When the aortic valve closes and the whooshing of blood against that, that's S2. Does that make sense? Cool. So it's really not that scary. It's just like a lot of lines. But I tried to break it up and color code it here. So then the other thing that I wanted to point out was this graph that he had posted. So I mentioned end diastolic volume. The other word for that is preload. I know he said that a few times. So it's just the max amount of blood that's in my ventricles after the atria have finally contracted, gets rid of all of its blood. My ventricles are fully relaxed and they're about to contract, right, in diastolic. So on this graph, it's 120. In systolic volume, they contract all their blood, or most of their blood. And then what's still left in the heart, right, is about 40. So that's end systolic volume. Stroke volume is how much I got rid of, right? So if I started with 120 and I ended with 140, that's a difference of 80. That's my stroke volume. That's how much blood I actually pumped out. This D part is where the volume rapidly increases. That's the rapid inflow. It's kind of like plateau where nothing happens. That's diastasis. And then when the atria finally contract and gives me that last little bit, that's the atrial systole where it contracts and gives me that last like 25. Does that all make sense? Any questions, comments, concerns, prayer requests? Sweet. So now we know everything there is to know about EKGs because we're super smart like that. So let's talk about when it's not normal. So here's normal EKG. And I know he mentioned this a lot in class where he was like, in order to determine what is the P wave, what is the T wave, what's the QRS, it kind of depends on what you're looking at. The easiest thing to find, obviously, is the QRS complex. And then you just look what's right before it, and it looks about the same in all of them. I'm going to call that a P wave. This looks like the same after all of them. I'm going to call that the T wave. P wave should always be positive. T waves can be positive or negative in like animals. In humans, not so much, but in animals, it's fine. I don't know why, it just is. So I have my normal sinus rhythm. Sinus just means my depolarization pattern is originating from the SA node, the sinoatrial node, sinus. Beautiful. So I'm going to get a PQRST every single time. It looks beautiful. It's regularly spaced. It's even. Everything looks symmetrical. It's boring. It's lovely. You can get a normal sinus arrhythmia. So when you breathe in, you are actually getting less parasympathetic innervation to your heart, which I'm going to talk about innervation in a minute, so don't stress too much about that. But parasympathetic is what slows it down. So if I get less slowing, it's going to speed up, right? So that's why if it's a normal sinus arrhythmia, when they breathe in, it speeds up just a little bit. I still get my PQRST. It's just a little bit faster during inspiration. Bradycardia and tachycardia, how I was taught to remember it was braiding your hair takes a long time. It's slow. If you sit on a tack, you're going to jump up fast. It's fast. It's helped me remember it. Maybe it'll help you. So bradycardia, it's slow. Tachycardia, it's fast. Bradycardia is normally some disease of the SA node, or I have high parasympathetic to sympathetic stimulation ratio. So more is slowing it down than what is speeding it up. Because a lot of times the parasympathetic and sympathetic innervation are working together simultaneously. It's just a ratio of the two that kind of sets my heart rate. So this is at rest. I get decreased depolarization. So the time between my T wave, which is when I finish my ventricular relaxation, and my next P wave, which is atrial contraction, is really long. This is always and forever abnormal. My SA node is not functioning as fast as it should be, or I have like overactive parasympathetic innervation. So I still have PQRST, but this P to P interval, even though it's not P to P, it's technically T to P. They just call it PP. I don't like that, but whatever, is really long. So again, always abnormal. Tachycardia, on the other hand, is high sympathetic to parasympathetic. So more is functioning to speed it up than it's functioning to slow it down. It's increased depolarization at rest. So those funny channels are reaching threshold a lot faster. During exercise, totally normal, right? During exercise, we learned that your heart rate has to jack up to balance out your high blood pressure. It wants to, or low blood pressure, so it wants to return it back to normal. So again, I still have PQRST every single time, but now my PP interval is really short, right? So if your dog is like riled up and is like super like terrified, this might be normal because it's going into fight or flight. Sympathetic involves fight or flight. But if he's chill, he's calm, he's not doing anything, and you have this, that's a problem. So then we get into the AV nodal blocks. So I said there's a delay between atria, AV, and ventricles. There's a delay right there at the AV nodal block. But sometimes that can be exasperated. So if I have a first degree, it just means it's slower than usual. So the time between atrial and ventricular depolarization is going to be longer than normal. So I'm still going to get this PQRST, right? It still is going to have all the components that it needs to have, but this PR interval it's going to be abnormally long. And that's what I was kind of talking about earlier whenever we were looking at the basic EKG. I don't think on the test he's going to give you like an EKG and be like, what does this dog have? But I imagine him to be like, if a dog has, you know, a long PR interval, or if he has a first degree AV nodal block, what will it look like on EKG? Or what disease does this reflect? That kind of thing. So don't stress too much about like reading it, because he was even saying like in class about like, oh, like even trained cardiologists like sometimes mess this up, but like whatever. So this is just slow. PQRST every time though. Second degree is sometimes that conduction through the AV node doesn't happen, right? So sometimes I'm not going to get a ventricular depolarization after an atrial one. So I'm going to get these intermittent Ps that don't have a QRST behind it. This can be caused by like drugs, cardiac disease, or whatever, but it's also normal in athletic horses at rest. This is because they have a lot of parasympathetic innervation to their heart, or a high ratio of parasympathetic to sympathetic. So much so that sometimes it's like causing this. I learned that. I did not know that before vet school, so don't make me think like I'm actually that cool. But that's something that I know he's going to put on the test, is something about this athletic horse, right? But whereas first degree, I'm always going to have PQRST. It's just a little slow in this PR interval. This one, I'm going to get some Ps without a QRST. And that's the big difference in reading it.
Gena.
Hey.
Will you say the thing about the horse one more time? Because I was like halfway zoned out. I just heard you say, oh my gosh, I know it's going to be on the test.
Yes, athletic horses at rest can look like they have a second degree AV nodal block. And it's just because they have a high parasympathetic to sympathetic tone to their heart because they're so athletic, if that makes sense. Beautiful. I don't know how the question is going to be worded, but I know it's going to be on there because he stressed that. So then third degree is I'm having no conduction through my AV node. So you're probably like, well, Gena, I see these ventricular contractions. How is that happening if it's not passing through? I'm glad you asked. And basically it's because the ventricles will essentially take over. They will recognize that they're not getting stimulated from the SA node. So some excitatory myoconducting cell in the ventricular mass will kind of assume the function of being a pacemaker. It's not effective. It's not as nice as it would be as if it were from the SA node, and it's not getting the correct stimulation that the body needs to adjust for its physiologic purposes. So say I'm running, right? I'm running and I need my heart to beat faster. I can get sympathetic innervation to my SA node. I don't have sympathetic innervation. I mean, that's poor. I don't have parasympathetic innervation to my excitatory cells in my ventricles, right? So it can't really react the same way as the SA node would to accompany the needs of the body. So it's hard to tell on an EKG, and that's what he was saying. But basically, there's a lot more P waves in between these QRSTs that are not accompanied by their own QRST. And like I said, these QRSTs are much slower, kind of random. If this dog is always at rest, it can survive, but the second that you like ask it to like start running, it's gonna like pass out because it's not getting adequate oxygen to the body because the heart rate can't increase to meet the needs of the body. And this will be fatal if it's not fixed. And it's always abnormal. So even athletic horses, this is always abnormal. So yeah, those are AV nodal blocks and stuff like that. Are there any questions, concerns? Cool. So then my next arrhythmia is ectopic ventricular contractions, or ectopic beats. So basically, some cell reaches threshold before it's supposed to. And we learned the all or none principle means that if one cell reaches threshold, all of the cells in that atrial or ventricular syncytium will then depolarize, right? All or none. So if I have some random cell in my left ventricle that reaches threshold and depolarizes before it's supposed to, the rest of my ventricle is going to depolarize before it's supposed to and cause a premature contraction. That's what the P stands for in PVC, premature ventricular contraction. You get random ventricular depolarization, random ventricular contraction, and that's going to give you a really weirdly shaped QRS complex. And that's because in happy, normal sinus EKGs, the depolarization passed beautifully down that septum and up the sides of the wall. I got the normal, pretty EKG. But if for some reason, say it starts at like the top corner and it goes that way, that's going to make my QRS complex a lot weirder than it's normally going to look. So that's what this guy is right here. It doesn't necessarily have to be preceded by a P wave because the QRS complex that you're going to read is not necessarily started by the atrial depolarization. I hope that made sense. I struggled to get that out. But basically what I'm trying to say is this depolarization is not caused by atrial depolarization. It's caused by some random cell that reaches its own threshold. If it's just 1, 2, or 3, I call it a PVC. If it's 3 or more in a row, that's when I call it ventricular tachycardia. So tachycardia meaning it's too fast, ventricular referring just to those. So I have some cell or group of cells in my ventricles that are reaching threshold and causing the depolarization and subsequent contractions out of line and way too fast, right? So I'm getting these really weird QRS complexes, like completely out of turn. So here's my normal PQRST, PQRST, and then just mass chaos, right? So that's ventricular tachycardia. The ventricles are going to start like pumping more than there is like blood. So I'm not going to get efficient blood flow or blood pumping out, if that makes sense. He didn't really talk about like signs and symptoms, but that's what it is. So then we have fibrillation. So those are like ectopic or PVCs or whatever. Fibrillation means that it's not caused by one specific cell reaching threshold and that depolarizes the rest of it. It means that fibrillation means that it's just kind of randomly happening, right? So this cell, and that cell, and this cell, and that cell, this cell, right? And so my atrial mass, if it's atrial fibrillation, instead of doing like depolarization, contraction, depolarization, contraction, it's just kind of doing this, right? Because all these cells are reaching threshold and depolarizing at random times, kind of back to back. And so it's just kind of like doing like this. So I'm not going to get a nice pretty P wave anymore because it's just kind of random. And I get this like fibrillation. I can't say this word. Fibrillation line where I should have P waves. I'm still going to get QRS complexes every now and then, but it's irregularly timed. But that's the fibrillation, right? Ventricular fibrillation, on the other hand, is literally just mass chaos because I'm not getting my pretty QRS complexes anymore. They're the ones doing this, and it's going to just literally look absolutely bizarre. This one is often preceded by VTach right here. And this one, if not fixed, is 100% like going to kill you, because if my ventricles are not effectively pumping out blood to my body, I'm not going to get the oxygen that I need. So if they're just kind of doing this, maybe giving me like 10 milliliters at a time, I'm not going to be able to supply my body with all the oxygen that it needs. So those are the arrhythmias and how they look on EKGs. How are we feeling?
So Gina,
Yes.
the VTAC is when ventricular part is like working super hard, and then sometimes it'll just like work so hard for a second that it'll go blah, 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 and get the last one.
Can you repeat that? I'm so sorry.
Sorry, that was not very like okay, word vomit. So the ventricular tachycardia is when like they're like doing that QRS complex like multiple times, right? So they're kind of like working a lot harder. And then
So-
that'll lead
Oh, sorry.
that'll lead to like the ventricular fibrillation because it's like doing that really hard and then it goes whoa.
So it's not necessarily caused by them like working hard. It kind of has to do with those cells reaching threshold at weird times. So this VTAC is caused by some area of my ventricle, whether it's one cell or multiple cells in a little region, are reaching threshold out of turn. When they reach threshold, that's going to cause the ventricular depolarization. If that area is like really fast at reaching depolarization and I'm getting these out of turn contractions like multiple times in a row, that's this VTAC. If you have like some disease, typically how it's going to progress is that you get VTAC, but then as the disease progresses, so does your, I guess, arrhythmia. So when the disease causes not just like this one little area or this one little cell to reach threshold, it's going to start causing maybe here and then here and then here and then here until it kind of isn't just like, oh, this one area is depolarized. Oh my God, I cannot speak. This one little area is not what's causing the actual contraction. All of these little areas are kind of causing or trying to cause contractions. So that's when my ventricles just kind of quiver and fibrillate and do like that. Does that make sense? Beautiful. Any other questions? I know that I got really tripped up on my words.
There is a question in the chat. The question is, what causes the S3 and S4 sound?
Oh yeah, for sure. So we don't really have to know those as much. He like didn't care about them super much. But basically it is so the third sound is the sound of that like rapid inflow changing to diastasis. So if I'm having all this blood rushing in and it kind of slows, you get a little bit of turbulence with that. And so that's what gives you that S3 sound. And then the S4 sound is caused by that last bit of atrial systole when it's getting out that very last bit of blood, and that little bit of turbulent sound gives you that one. You really won't hear those unless you have like super nice equipment and are doing like actual cardiac work, but I don't think he really cares about those. Does that make sense? Dope. Cool. So then the last thing that I had was like innervation and control. So this is all like the hormones and parasympathetic, blah, 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 blah. Some of this is just like rote memorization, but hopefully we can make some of it make sense. So I said parasympathetic, it slows it down. Sympathetic speeds it up. So how does it do that? Parasympathetic is going to bind acetylcholine muscarinic receptors, versus sympathetic is going to do alpha 1 and beta 1 receptors, right? And it's binding norepinephrine and epinephrine. So in the heart, if the parasympathetic is acting on it, right, that is going to keep my potassium channels open a little bit longer than normal. So if you think back to when we had those action potential plateaus, part of the reason why it plateaued was because the potassium channels are opened a little bit longer than the calcium channels. if I keep that open longer, I'm prolonging the time that it's going to take to recause a depolarization, right? It slows the depolarization rate, so therefore my heart rate slows down. Sympathetic, on the other hand, it acts on the funny channels. So the HCN stands for hyperpolarization gated, I don't know the full term, but camp sodium channel, Na channels, right? So this cyclic AMP speeds up the reaching of threshold, right? So norepinephrine and epinephrine cause an increase in cyclic AMP, increasing, I think I said increasing opening, basically just like more of those channels are open, not like the individual channels are like, I don't know how to describe what I was trying to say, but basically like more of those channels are opening collectively, causing the cell to reach a depolarized state faster. So that's going to increase my heart rate. I hope that made sense. If not, I'll go over it. The sympathetic innervation, and this is all in the SA node. The sympathetic also can act on the contractile cells to cause the force of contraction to increase. And then it also acts on vessels to cause vasoconstriction. And that's in those non-vital tissues, right? Which we talk about a little bit later, so don't worry. So overall takeaway, sympathetic speeds it up and parasympathetic slows it down. I know he's going to ask about like the actual hormones or whatever. So just, I guess, make sure you're aware of those. So adrenal medulla. So they have these things called chromaffin cells, which are, as I wrote here, like structurally similar to postsynaptic sympathetic neurons. Basically, what you need to know is that the adrenal medulla releases epinephrine and norepinephrine into the circulation. So epinephrine and norepinephrine we talked about up here, right, as part of the sympathetic division. So the adrenal medulla acts in concert with the sympathetic division, specifically during like fight or flight. So yeah, it has similar effects on the body as the sympathetic division. So how do I control my heart rate? So we talked about that a lot. So things that control your heart rate are chronotopes. It can be positive, it can be negative. Positive meaning it speeds it up, negative meaning it slows it down. So like I said earlier, at all times, I'm going to have both sympathetic and parasympathetic stimulation. And the balance or ratio of that kind of determines my heart rate. So it's not the case where I have like all of one and none of the other. It's just which one kind of takes precedence. So I'm working on both my muscarinic acetylcholine receptors, which is parasympathetic, and the beta 1 receptors, beta 1 adrenergic receptors for sympathetic. I know he mentioned atropine, which is a drug. Atropine blocks parasympathetic innervation, so it can actually increase the heart rate. If this slows it down and I'm stopping the slowing, it's going to increase. I just wrote that in there. I don't know if he's going to ask about that or not, but I know he mentioned it, so I just wanted to point that out. So yeah, that's controlling heart rate. So now to control stroke volume. So remember we said that stroke volume is how much I'm actually getting out per contraction, right? So I can control that in two ways. Number one is my preload or my end diastolic volume. Same thing. So we have the Frank-Starling law of the heart, which basically just says the more that I stretch it, the more it's going to give out, right? So if I increase the volume of the blood that is in the ventricles, I'm going to increase how much I'm stretching them. And so they're actually going to pump harder and eject more. And so that's controlling my stroke volume. basically, how do I change this? I have to increase my venous return. So it's kind of a whole situation. So if I am increasing venous return to the body, I'm increasing the stuff that goes in, or the blood that goes into the right atrium. I'm eventually increasing it to the right ventricle, left atrium, left ventricle. That's how I get this increased stroke volume. Does that make sense? Like it's kind of like a whole thing. So that's why we talked about, like, in the case where I have like profuse watery diarrhea in a horse, if he's losing a lot of the plasma in his blood, I'm getting less venous return into those atria, thus less blood in the ventricles, less stretch, decreased stroke volume, which decreases blood pressure. Does that make sense? It's kind of a whole chain of things. Cool. The other way I can control stroke volume is the actual contractility of the myocardial contractile cells. So that's kind of what I was talking about with the sympathetic, how it can act on the SA node, or it can actually act on the contraction of the heart itself. That's what this is talking about. So again, if I bind, I'm going to bind to these beta-1 receptors, epinephrine, norepinephrine. So if I'm increasing sympathetic, I'm getting more epinephrine, norepinephrine binding on those beta-1 receptors. Specifically, what is that going to cause is more free calcium. If you remember how the actual action potential works, or not action potential, but the muscle contraction works, is I have free calcium. That is going to cause a calcium-mediated calcium release. So the extracellular calcium actually triggers the sarcoplasmic reticulum to release its intracellular calcium. So if I have more on the outside, I get a stronger contraction because I'm releasing more calcium on the inside for the actin, troponin, tropomyosin situation. Stronger contraction gives me a stronger stroke volume, or not stronger, but greater. The exact opposite happens if I decrease sympathetic. I'm going to decrease the amount of free calcium. I'm going to get a weaker contraction. I'm going to decrease my stroke volume. The other way that stroke volume decreases as far as like contractility of the myocardium is like bacterial toxins. It can affect that as well. And then the last one that is kind of in this like cardiac output formula is the total systemic, I'm blanking on what the V stands for, but resistance, right? Vessels, I don't know, whatever, it doesn't matter. So this is specifically arterioles, right? So we said that arteries do not change blood pressure, right? Arteries can either expand or not contract, but what's the word when they like go back to place? They have like elasticity, whatever that means. So it's specifically the arterioles, not the arteries. The smooth muscles in the arterioles have innervation. So it's the balance of intrinsic, which just means in that specific tissue, or extrinsic, which is kind of not localized, it's everywhere in the body. And it's still going to be epinephrine and norepinephrine, but now it's alpha-1 receptors. So beta-1 is in the heart, alpha-1 is in the vessels. So intrinsic just means that, say I am like doing curls. He always talked about his great big biceps, right? I'm doing curls. So now my bicep muscles have a greater metabolic rate, right? So that's intrinsic. My arterioles in my bicep are going to vasodilate, which is going to decrease resistance, right? If I have a bigger area to pass through, it's not as hard to pass through it. And that's going to give me increased blood flow specifically to that tissue, right? Extrinsic means I'm decreasing, and I didn't write it very well. But this is just like in that tissue. So I'm not dealing with like sympathetic control at this point, right? That's just like reflex. Extrinsic means not localized, it means pretty much everywhere. So if I'm decreasing my sympathetic stimulation of these alpha-1 receptors, that's going to cause vasodilation, because we said sympathetic causes vasoconstriction. So if I'm decreasing sympathetic, I'm getting vasodilation. That's going to decrease resistance, and that's going to increase blood flow to all of my tissues, not just one localized area. So then you get the concept of like vital tissues and non-vital tissues. So vital tissues are like brain, spinal cord, heart, things like that, breathing muscles. So intrinsic is really effective for vital tissues versus extrinsic really affects non-vital tissues. For example, if I am going into fight or flight, I'm running away from a bear, is what you always like to say. I'm going to get sympathetic stimulation throughout my body, right? My sympathetic nervous system is going to start going into overdrive. I'm going to get epinephrine, norepinephrine all over. My heart rate's going to increase because it's binding to the beta-1 receptors. My alpha-1 receptors on my leg muscles, or not my leg muscles, my bladder per se, like I'm not worried about peeing right now, or my uterus, like I'm not worried about making a baby right now, I'm trying to get away from a bear. It's going to vasoconstrict or did I write that right?
Sure.
What's that?
Cheese.
Oh, thanks.
Uh-huh.
I have chips and queso. But yes, sorry. So extrinsic really affects like the non-vital tissues. So I'm talking about increasing sympathetic stimulation. So it's kind of backwards of what I wrote. But yeah, I'm not worried about peeing and making a baby when I'm running away from a bear, but I don't want to decrease sympathetic stimulation to like my heart because I need it to do its thing. I don't want to decrease it to my brain. I still need it working at its optimal. So that's the difference between like vital and non-vital. And then the other one was like skeletal muscles, was like skeletal muscles are vital during exercise, but non-vital at rest. So like if I'm trying to run away from the bear, I need my skeletal muscles, those become vital. But if I'm just like chilling at home, I'm not running away from anything, that's non-vital. But my brain is still vital. I kind of muddled my way through that because I got very distracted. Does that make sense what I just tried to say? Okay, cool. So this is all affecting like cardiac output and like blood pressure. So then the last few things are I have input from higher centers in my CNS. So that's like when you talked about the example of like, I know I'm about to do something, like I plan it ahead. So higher centers in my brain are going to send a signal to my cardiovascular regulatory center to prime it. So if I know that I'm about to go run, it's going to send those signals to prime everything, right? The arterial baroreceptor, those detect stretch. So in the case of I have profuse watery diarrhea, where I'm losing blood volume and I'm getting less stretch, it's going to detect that, and it's going to cause effects that will increase my blood pressure back to normal, if that makes sense. And it's short-term control to oppose variations. I also have chemoreceptors. That mainly deals with like carbon dioxide and everything. He doesn't really talk much about that. Basically, if I have a lot of carbon dioxide, not a lot of oxygen, my heart rate's going to increase because I want to get more oxygen out to my body. And then the last one is the renin, angiotensin, aldosterone system. And the baroreceptor system really kind of opposes the minute-to-minute variations. in blood pressure. This system kind of gives me like long-term control of my blood volume and sets the normal point for my blood pressure. So renin is released by the kidneys. That's going to cause angiotensinogen to convert to angiotensin 2. That gives me vasoconstriction of non-vital arterioles, right? If I am constricting, I am increasing my TSVR, my resistance. If I increase resistance, I'm increasing blood pressure. And this happens instantaneously, right? So this is in the case of like stress. Angiotensin 2 can then cause the release of aldosterone from the adrenal cortex. Aldosterone causes salt and water retention by my kidneys, and that's going to increase my blood volume. And that takes like hours, days. It's not so instantaneous. So this is like the long-term blood volume control. And it kind of gives me like a normal set point for my blood pressure. So those are all the different ways that I can control heart rate, blood pressure, stroke volume, resistance, and all of those function because mean blood pressure is one of the most important parameters in a body. Like it causes so much, either good or bad. So that's kind of that simplified. So that's all of the cheat sheets that I had. I know that you guys were like, I don't know what I don't know. So hit me with it. Any questions now that I'm through my rant?